brief introductions of each speaker. There's more detailed information in your program book, and we will provide the CE verification code at the end of each presentation. You can use your laptop or mobile device to report your CE, or you can stop by the special CE kiosk at the registration desk. And to make it as convenient as possible, you have 30 days following the conference to report your CE credits online. Check your on-site program book or the insert in your conference bag for complete details on our new CE submission process. Now on to our program. Our first speaker is Dr. Allen Honigman. His presentation is entitled Laser-Assisted Peri-Implantitis Procedure and En-LIGHT-ening Treatment. Please welcome Dr. Allen Honigman.
Wow, those lights are blinding. Thank you very much, Dr. Iyer. I just want to thank the AID for allowing me to give a presentation at for this very auspicious group. So today's lecture is going to be on laser-assisted peri-implantitis procedure. I call it an En-LIGHT-ening treatment. The first question I want to ask is, how many here, this is your first time to New Orleans? Okay, little known fact, if you get stopped for drunk driving here and your blood alcohol level is lower than the police, you get off. They'll just let you go, don't worry about it, it's fine. So, all right. You know, I really thought that was going to get a bigger laugh, but it's early, and there's coffee and everything. So let's get started. All right, here we go. So this is me. My parents were very happy when I finally finished my residency, so I could actually start working again. So I did my residency at UCLA, finished in '93, and I worked at Case Western Reserve University for a while. 2006, I was looking for a way to treat periodontal disease rather than our traditional cut and sew procedure. I was trying to separate myself up from the other periodontists in town, and this laser procedure called LAPIP was starting to come up, and so I started to, I looked into it. I became the first periodontist in Phoenix to perform it. And I liked it so much I decided to become an instructor for them and to help teach other periodontists and other general dentists and other oral surgeons how to treat periodontitis with using a laser-based procedure. And there are actually some of you out there right now, which, hello. And then 20 years later, after my residency, actually almost 22 years later, I decided to finally get my board certification. So 2 years ago, I decided to get my board certification to become a board certified periodontist, one of the goals that I wanted to accomplish after becoming a periodontist. Here's my disclosure. I am an independent consultant for Millennium Dental Technologies, and I'm instructor for the Institute for Advanced Laser Dentistry. This is where I live. I live in Phoenix, Arizona. We're a little close to the sun. We're getting cooler now. It's down to the 90s, so we're pretty happy about that. Of course, it's pretty warm here in New Orleans. Everyone's talking about it. Doesn't feel like Halloween yet, so who knows. But I'm glad I'm not in Yuma during the summertime, because that's just unbearably hot. I always like to show that video first, because first it gets a good laugh and relaxes everybody, but also it really shows that even what you think may be innocuous laser, even a little diode, without proper training, can be a dangerous thing. So if you're going to buy a laser, or you're thinking about it, please make sure that it comes with great training, so you won't hurt your patients. And that's really, really important. There are a lot of stories out there that I'm sure you'll hear. So what exactly is a laser? How many people here, how many attendees here actually have a laser in their practice? That's pretty good. That's really good. How many actually know what type of laser they have? You'd actually be surprised how many people don't know that. They go, well, it's a laser. The guy said, here's a laser, buy it, and you'll make a lot of money. So, but you'd be surprised how many people actually don't. So what exactly is a laser? You get a little physics lesson here. A laser stands for light amplification by stimulated emission radiation. That's all you need to know about that. laser types are based on where they interact. And this is really important. There are hard tissue lasers, they're mostly the erbiums, the erbium YAGs, the erbium YSGGs. And the soft tissue lasers are basically the Nd:YAGs, the diodes, the CO2s. Now, erbiums will do soft tissue work, but they're mostly going to develop for hard tissue, treating teeth, etc. There we go. So, laser interaction can go through a host of different ways. You can have, it can be reflected, it can be transmitted, it can be scattered. If any of those happen, nothing happens. So that's why, if you shine a laser, one of your little handheld lasers, something like this, at the screen doesn't burn up because that's not where this particular wavelength is absorbed. Nothing happens until the wavelength is absorbed by your target tissue. That's dependent on the laser wavelength, the tissue composition, the pigmentation, and the water content. So nothing happens. So if a laser company says, oh, our laser can do this, and it's not absorbed, it doesn't really make a difference. You can't change physics. So this is just the electromagnetic spectrum. You can see here what we see, the visible light, and on the, let's see, facing you would be the left side, would be the ionizing radiation, or ultraviolets, or X-rays, and on the left side, on the right side, you have your invisible, which is the near infrared, mid infrared, and far infrared. This is where most of the lasers fall into, is in that category. There is no device in laser dentistry or medicine where one laser is equally good at treating all tissues equally well. That's important. So you have to look at, before you buy a laser, you have to kind of look at, what do I want it to do? And that's, if you want it to do one thing, don't expect it to do something else, another procedure really well. So if I want a laser that cuts bone, it's not really going to do as well, maybe treating perio, which we're going to see. So you have to kind of look at that. So one laser can't do everything equally well. Very important. So what does it mean clinically? Whoa, what do you got? Oh, someone changed this stuff. What we'll see is in pulsed Nd:YAG lasers, it's transparent to water and cell membranes. You see this a little later. It's highly absorbed in dark pigment, and it's well absorbed in hemoglobin. And not well absorbed in connective tissue. Let's go on. So this, I think, really shows what the Nd:YAG can do. We'll talk about this. For some reason. This really shows the specificity of the Nd:YAG laser. No other laser can do that. No other laser can do that. The erbium can't, and a CO2 can't, and a diode can't, because of how the Nd:YAG is absorbed in dark pigment. So I'm going to go back one, because I think one of my slides is missing. But let me talk a little bit about where things are absorbed. Erbiums are highly absorbed in hard tissues. So like hydroxyapatite, it's very highly absorbed. It's also highly absorbed in water. What are we mostly made of? Water. Last night I was bourbon and wherever, but today it's water. The idea is that if it's absorbed in water, it has a very low penetration. It can't penetrate deeply, because once it reaches that first layer of cells, it's done, it's history, it can't really go any further. It's highly absorbed hydroxyapatite. Well, hard tissues, that's great, because erbiums were initially developed to treat teeth, to do cavities and things like that, and to cut teeth and whatever. It also cuts bone. If I'm treating perio, do I want a laser that cuts bone? No, I want to keep as much bone as possible. So an erbium really is not the laser that I want to use to treat perio. And the reason I'm talking about perio is if I don't tell you how we got to LAPIP, or the laser-assisted procedure to treat periodontitis, it's a big jump. I have to show the evolution. CO2 is highly absorbed in hydroxyapatite, or hard tissues, and water. So again, very low penetration, but high heat. I don't want to use heat to treat anything around bone. So again, CO2 really is not the laser I want to use to treat perio. Nd:YAGs, however, are not absorbed in water, so they'll pass right through, kind of like the balloon. It passes through the balloon to reach this target, which happens to be dark pigment, dark tissue, inflamed, dark pigment bacteria, etc. So it can pass through cells to get to its target without damaging the cell itself. So it's not going to remove non-diseased tissue. It's really only going to remove diseased tissue. It's also moderately absorbed in hemoglobin, which allows us to develop fibrin clots, which you'll see a little later. But This really shows the specificity of what an Nd:YAG can do. No other laser can do this, and this is a simple physics. So if you saw this in your office on Monday morning, what would you do? Some people say refer to the oral surgeon. And I always tell them, well, are you going to take away that much time? Well, if it's your mother-in-law, yeah, you know, I would probably do that. But if it's your patient, you don't want to do that because you don't want to take away that much time. And if you try to puncture it, it's just going to bleed everywhere. I saw this patient and I said, well, I knew the Nd:YAG is absorbing hemoglobin very well, but it's not really well absorbed through tissue that's not red. So we treated it. Now, this is one treatment I'm going to show you, and you can see here, so that's the initial treatment. This is immediately post-op. I didn't puncture this, it's not bleeding. The laser is actually being absorbed by the blood. 2 weeks later, that's what it looks like. 4 weeks later, that's what it looks like. No char, no bleeding, very simple, but using laser physics and where interaction happens, we can do things like this. Or we can do things like this, gingival depigmentation. Very nice, this patient came in, wanted this to look better. I said, okay, well, we'll treat it with my laser, because the other option that you got from another periodontist was we'll take a Diamondberg and strip away your outer layer of gum tissue and then maybe graft some tissue on top, which sounds absolutely brutal. So we treated her, this is what she looked like. I did half her mouth because she only paid half the fee. So, you know, this way you know they're going to come back and get the other half treated. Now I want to show this, why? Because it's just a nice contrast. But this is what she looked like right after. This is one treatment. What you're seeing here is the underlying tissue. Now, does it look burned? Does it look charred? Does it look dead? Does it look necrotic? No. It's healthy, connective tissue underneath there. This is what's happening inside a periodontal pocket when we treat with the LAPIP procedure, is removing diseased tissue, leaving behind healthy connective tissue. This is what she looked like a week later. And this is what she looked like 4 weeks later. Very nice, we got a little bit of the melon coming back, but not to the same extent. I think this is a lot more aesthetic than having bright pink gums. And she was very happy, had very little discomfort. So if you had a choice between, if you were going to have, let's say, back surgery, and you could get a laser treatment, a treatment done with laser, or a treatment done with traditional cut and sew, and you're going to get the exact same result, how many here would choose the cut and sew? I've yet to someone put their hand up. Because nobody wants to get their back cut. If you can get the exact same result by having an easy, simple laser treatment as opposed to the more traditional, why would you want to get the more traditional? Now there are probably cases that the Laser Spine Institute can't do because they just require traditional cut and sew. So all this person had was a laser treatment done for their back problems, and now they're on the beach with a little Band-Aid, which is nice. That's what we want for our patients. Low trauma, easy procedures. Because this is what people think, and this is what perio used to be, and perio sometimes still is this. We just cut away the gums, functionally the patient's fine, they can keep these are maintainable pockets, but no one comes in and asks me for what I call the picket fence. No one's ever walked into my office and said, Dr. Honigman, cut away my gums because I want to be able to suck spaghetti without having to chew. No one's ever said that. And there's an aesthetic problem. I'd rather a patient have gone through get dentures than put them through this for the rest of their lives. I just think this is, to me, it's a functional success, but to me it's a failure. The most dangerous phrase in the language is we've always done it this way. And when I started doing laser procedures, periodontists say, no, why would you want to do it? We've always done it. My own father-in-law, well, my future ex-father-in-law at the time. Someone got that joke, thank you. He said, why would you want to do this? Why would you want to get involved in this? The old ways always work, you know, open it up, clean it up, close it up, do some regeneration. But once we start getting into a thing saying we've always done it this way, I think we start losing ourselves. No one ever thought, I remember when don't forget, I finished my residency in '93. Implants were coming up. The thought of doing an immediate implant was crazy. Placing an implant into a socket right away, are you nuts? Doing sinus lifts, that's the purview of like oral surgeons, and let them handle that. Regrowing bone on a regular basis without thinking about it, resorbable membranes weren't even around. So we have to evolve. We have to find new ways to do procedures that help our patients. So the LAPIP protocol was developed by two general dentists, Dr. Bob Gregg and Dr. Del McCarthy, because they got tired of their patients going to periodontist and only having part treatment done, or half mouth, or not getting any treatment done. Because when you send a patient to the periodontist, there's only two things they're thinking of: how much does it cost, and how much is it going to hurt you? That's it. The rest is all, well, whatever, but how much is it going to cost, how much is it going to hurt? So the LAPIP protocol was developed. Recently, the LAPIP protocol was given FDA approval for being true regeneration, something that those of us who have been doing LAPIP for a while have actually know we have it, but now it's been FDA approved to say it's true regeneration. And true regeneration requires three factors: new cementum, new PDL, and new alveolar bone. It's the world's first ever FDA clearance for true regeneration. No other laser company, and I'm not here to sell PeriLase, I'm trying to explain to you why, but no other laser company can make this claim. No other laser-based procedure can make this claim. No other laser-based procedure has the histology or the scientific background to make this claim, and that's important. There's histology. Histology's out there. Dr. Mark Nevins redid Dr. Ray Yekna's study, but with more multi-rooted teeth and a longer healing time. And you can see here, it was a 9-month evaluation of the LAPIP protocol. And what you can see is there is new cementum. I think there's a bigger picture of it. There it is. So there's sharpness fibers directly inserting into new cementum in the correct orientation. We're getting a brand new PDL showing up exactly what it should look like in the mouth. And you got new cementum, we have dentin, and that's it. So we have regeneration at the histological level. And this is just another slide showing it again. The periodontal ligament fibers directly inserting the correct orientation into the new cementum. It happens. How many here use diodes to treat, to do like decontamination in their offices? A lot of people do. It's like a big thing now. The problem with the diode is it only kills bacteria at the surface. It doesn't extend past the point of contact. NDX can extend past the point of contact up to 2 to 4 millimeters. So there was a study done by Dr. Dave Harris on looking at PG javalis, and what they found was the kill rate for an NDX was 16 times greater than that of a diode. And the other thing I'm going to tell you is if you buy a diode is a diode is a diode. I don't care if it's 810, 980, 1064, it's still a diode. It's basically electrosurge with light. That's all it is. It's a hot tip. So that's all it is. So base it on price. Don't base it on really anything else. Maybe the cool factor if it's like a small little diode. But the point is that the Nd:YAG was 2 millimeters into the tissue, whereas the diode was just surface. So you're getting bacteria kill past the point of contact. That's important. PG hides. It hides in the privileged sites. It hides in the dental tubules. It hides within the bone. It hides within the connective tissue. It hides within the cells. It hides. You can't get it with scaling and root planing. And you can't get it with surgery because it's hiding inside. You're not killing it. You need something that's going to get into these little sites without damaging the tissue. And because the Nd:YAG laser wavelength does not damage hard tissue, we can use it near dentin, and those photons are going to get inside those dental tubules. And it's going to get within the bone without damaging the bone because it's not absorbing hard tissues. So this little cartoon, I guess, the little spiders represent bacteria, and you can see here, it's getting in the bone, in the cementum, in the calculus, in everything. It's like a little nuclear blast past the point of contact. Dr. Tom McCauley and Dr. Thomas Rams decided to do a little study because they wanted to see when is the bacteria kill happening. Is it happening at the time of the laser treatment, or is it happening after? And so they decided to do a study using doing LAPIP on patients and also doing ultrasonic debridement on patients. They did their samples. What they found was 17 or 85% of the sites that had LAPIP done, 100% of the putative periodontal pathogens were gone immediately after. Bacteria kill is immediate. It's not something that the body has to take care of later on. The kill is immediate. What they also found was 100% of the sites with ultrasonic debridement still had 100% of the puboperiodontal pathogens. So although our scaling and implanting procedures work to get rid of calculus, it's not getting rid of the bacteria. The bacteria is still present. The tissue may look cleaner, but the bacteria is still present. My feeling is that's why we get these relapses on patients, because we're not killing the source of the problem. We're getting rid of what's hiding the problem sometimes, the calculus, but we're not getting rid of the problem. So this is something that Dr. Jim Kim did. Dr. Kim was a resident right after me at UCLA. And so he started doing LAPIP a little while ago, and so he wanted to see where's the kill happening. So he actually did this on a phase contrast, and you'll see it. And this is kind of interesting because he's using the laser directly on the glass slide. You can't do it with another laser. So there's the parallel fiber, and he's doing it right on top of the glass slide. And not long also. I mean, it's like 10 seconds or 12 seconds, whatever it is. And now he's looking, and you can see the bacteria are pretty much dead. This is an immediate response. If you tried it with immersion or CO2, you're going to boil water, and the whole thing's going to destroy itself. It's going to blow up on you. So you can't really do it with another laser. But this one, it passed through the glass, passed through the water, just to kill the bacteria. So, I'm going to can we turn the sound down on this particular video, please? Thanks. So this is just a little animation, and the reason I'm showing this is because this is kind of what we do in the mouth with the LAPIP procedure for implants. So what we're doing here is we use a laser to open up the tissue. We're getting rid of diseased epithelium, diseased tissue. We're killing bacteria. We're not cutting away the tissue that's not diseased. The disease for periodontal disease is on the inside, not the outside of the pocket, so we don't have to amputate tissue away. We're killing bacteria at the same time, like I said. Don't forget, it's past the point of contact. Then we go in and we scale the root plane. We use piezo scalers. I use piezo scalers. I have not used a curette for scaling and root planing, and I know this is going to blow some of his minds over 10 years. I don't use curettes anymore. But I use piezo scalers to remove the calculus. We have to remove all the calculus. Yes, you have to remove as much as you can. So we remove the calculus. Then we use laser again on a different setting, again, to kind of kill more bacteria, remove what we can. But now what we're doing is we're trying to develop what we call a fibrin clot. And the fibrin clot, we're splitting fibrinogen into fibrin, and we're getting a clot to form through heat, which allows us to treat patients who are on Coumadin, etc., without having to take them off their medications, which is nice. So this is just basically a slide showing it again. If we go to Wound Healing 101, you remove the infection from the tissue. This is real simple. Kill the pathogens, clean the wound, create a stable clot so things have a habit that can heal in. And we want to keep the clot there while it heals. We don't want the clot to break up, so we adjust the occlusion. And this is just an example of the fibrogenic clot. You can see how sticky it looks. And you can see what that snow is. That's porcelain powder during the occlusal adjustment phase. But look how that clot is stable. It's not moving. This is done with a high speed on air only, obviously. We don't want to wash away anything, but you can see that that clot is sticky. It's a gelatinous mass that's really going to happen to the patient's own barrier. And so I like it so much, I said, well, what if I try to do it during connected tissue grafts so I can avoid doing sutures? So this is a case that I did. First one, didn't get any calls. The patient didn't call me. I give everybody a palatal stent. You know, a week later, it looks like this. 4 weeks later, it looks like that. Healed in, beautified in, put stitches in. Again, using laser physics. When we talk about lasers, sometimes you have to unlearn what you've already learned. And that's important. Because what we think may not actually, we have to kind of adjust what we've been taught in the past. So the cases I want to show you, other than the ones that come from other doctors, are all mine. And all the cases have only been treated once. And this is important to realize, only once. They didn't go through multiple cases, they didn't do multiple LAPIP treatments, only once. So as a patient came in, you can see the amount of calculus, you can see the amount of bone loss he has. I gave him 2 options. I said, we can save your teeth or we can take your teeth out. Which do you want? He wanted to save his teeth. That was it. He couldn't afford implants, he couldn't, I didn't want to put in dentures, but I could save his teeth. And that's what's important. He wanted to keep his teeth. So here he is, you can see how much bone loss he has, how much calculus there is. Cutting the, doing scale root plane, these pockets were 10, 11, 12 millimeter pockets. Scale root plane is really not going to help that much. It's just I wouldn't even call it duct tape. It'd be like doing nothing. And cutting is just going to leave him with a picket fence, which is unacceptable to me. So this is what he looked like when he was treated. This is not after treatment, obviously. This is the day he came in. We did his treatment. This is one of the teeth I took out. You can see the calculus that I was trying to fight to take off. Here he is, right after treatment. The blood you're seeing, that's our fibrin clot. And this is what he looked like 4 weeks later. We stabilized his teeth with a stent, with a splint. And look how nice that tissue is. Do we get recession? Yeah, we got some because of recession, because of inflammation. But look, the gums look pretty good. They're pretty healthy. And he's able to keep it clean now. And he's happy with it. Here he is 6 months later. There's actually 3 months after we did treatment. Here's 9 months. And he's, it's looking good. Tissue staying nice and pink and healthy. The original pocket depth on this was 11. And look, I didn't have to cut away 9 millimeters of tissue to get a 2 millimeter pocket. And this original pocket depth was 10, and now it's a 4. Again, without cutting away tissue. Saving the patient's teeth, getting a new attachment to occur. Here it is 22 months later. Here he is 29 months later. I just saw him on Monday. He loves his teeth. I changed his splint to an internal splint on the lingual. And he's looking great. Inflammation control, fantastic. I don't think there's another procedure that I can do, or anyone can do, to get inflammation control like this. Here's another one. There's no medications involved. This patient is not on anything. This is pure parainflammation. Where would you even start with this patient? Scale, root plane, surgery, take teeth out? I want to get the inflammation down as fast as possible. I would did LAPIP on him. 6 months later, this is what it looked like. Again, 1 treatment. He's in for his 2nd maintenance now. But look how nice the tissue's kind of shrunk down. It's settled. We can go ahead and start some restorative work if we need to, but we can see where we need to maybe do some touch-up work. Here's his lower, same thing. Where would you start? I didn't want to take any teeth out on him because I couldn't give him a partial because I don't know where the tissue's going to end up at. But 6 months later, this is the way it looks like. Save the teeth. Tissue went down. Now we can stabilize them if we wanted to. We can do restorative work. But he was happy. He saved his teeth, and that's all he cared about. And that's what we want for our patients. We want to try to save teeth if we can. I know I'm talking to an implant group, but it's kind of weird. So inflammation control, bacteriological control, histologically we can prove it. What's happening in the bone? Here's a traditional case. Everyone sees these all the time. What do? Take the teeth out, do regenerative. What are you going to do for regenerative? You're going to do bone graft, membranes, embryoing, you're going to use biomimetics. What are you going to do? Because everything you add adds a cost to the patient. At some point, the patient says, I can't afford that, doc. What else can you give me? So we went ahead and treated him. 6 months later, that's what we have. Don't forget, it's 1 treatment. There's no exogenous bone graft in there. And then a year later, you can see here, the bones pretty much come back. I was taught that can't happen. 20 years ago, this wasn't supposed to happen. And now they say it can't happen unless you put bone graft and PRP and everything else in it. But look, it happens. Pockets went down 12 to a 6 without cutting away tissue, 10 to a 3. That's amazing. Here's another case. A 13 millimeter pocket. I mean, how are you going to, you can try to regenerate that, I guess, but it's a lot of surgery and how much tooth is going to show, etc. Maybe just take a tooth out, graft it, see what happens. 10 months later, that's what it looks like. Again, 1 treatment. 20 months later, and there is 27 months later, it still heals. Until you get a functional lamidura, that bone will still come back. And the patient's only coming in for 3-month maintenance. I did not retreat this case. That's pretty good. Pretty happy with that case. And that's what the tissue looks like. If you saw that, you would not expect the patient had the 13 millimeter pocket in that area 2 years ago. Because we really didn't get any recession. This patient here came in, I'd seen her before, she didn't want to get LAPIP done, and finally she decided to come in 3 years later. I decided to take an x-ray just after doing LAPIP on her, a few months down, 9 months down the road. I want to see what's going on. I really thought I was going to end up taking this tooth out. You can see the amount of bone loss, you can see the amount, anyone would have taken this tooth out. Here's what she looked like 10 months later. Bone filled in, and she's not the greatest cleaner. She still hasn't got the hygiene part down, she's getting there. But 10 months later, we got that bone. That tooth's still in place. Over 16 months later, I know I'm seeing her again next month. So what's that? That's going to be almost 2 years, 20 months. down the road, that tooth is still in place. We're keeping her in their teeth at least until she can afford to get implants done, or something a little bit more stable. But we've saved the tooth in a sense. What about this patient here? Most doctors would say take 5 or 6 teeth out, get him implants, this and that. What if the patient can't afford implants? You're going to put him in a partial? I'm not a big fan of partials. Went ahead and treated him. We're going to look at tooth number 18 and 19 mostly. You can see the amount of bone loss. How many here would take those 2 teeth out? Okay, just go ahead and admit it, it's fine. It's not, is it a bad treatment? No, it's what most of us would do. I didn't expect anything to happen. Here's what it looked like 6 months later. You know, tissue looked good, all right, fine, tissue looks good. If it's looking good, leave it in. Bone was coming back. Here it is 30 months later. 1 treatment, mind you. Here's 6 years later. Here's tooth number 19 that most people would say needed a root canal. But we don't. Am I going to get bone all the way to the top of the CEJ? That's not going to happen. But I've got bone to where I can't get bone, and the rest is just, he comes in for regular maintenance every 3 months. The guy's amazing. Implant or something else. Here's another one, tooth number 30. You can see it's great. You know, we have a 10mm pocket on number 30, and now we brought it down to a 5 after treatment. Here's the tooth. I don't know what's wrong with it. I mean, my guess is it's an occlusion thing. 9 months later, that's what it looked like. That looks pretty good. Here, oh, I didn't put the 2.5 years in. Someone took out my slide. There's one for 2.5 years in there also. How many here would take that tooth out? On number 9, this is a lady in her 70s. How many here would take that out? Everyone told her to take that tooth out because get an implant done. We ended up treating her. 13 months later, complete bone fill with 3mm pockets. And just to show you, that arrow should be over the number 9 tooth. You can see the defect, and now you can see how it's filled in again. Well, that's not a Implant 3D study that I did. And there's the tooth, number 9. She liked it so much she went and had ortho done, had Invisalign done. So the LAP protocol, I like to think, gives hope to the hopeless. But there's a link. Now this is where the link comes in, because there's a link between peri-implantitis and periodontitis. It's basically caused by the same pathogens. If you have a patient who has periodontal disease and it's rampant, why would you place implants in the patient's mouth? You got to get the peri under control first before you start putting implants in. Otherwise, you're looking at a failure down the road. You're looking at peri-implantitis down the road. So, if we can treat periodontal disease with a laser-based procedure like LAPIP, why can't we treat peri-implantitis with a laser-based procedure? So, because we're basically taking care of the same things. We're taking care of the same bacteria. Peri-implantitis, and you know, I'm talking to a group of major implant placers, probably more than me, about what the problem is with implants. You know, we all thought maybe 20 years ago that implants are great. They're not natural teeth, so we're not worried about cavities, root canals, sensitivity, etc. But how many of us were expecting to see all these problems starting to come up at this point? Because peri-implantitis is becoming a major health problem. The literature, however, is lacking in what the predisposing and directing treatment for. How do you direct your treatment protocols? I was the AAP and I went to the corporate forum. I went to 2 lectures on peri-implantitis. One was, one doctor said, lasers aren't any better than for decontaminating implant surfaces, other than they actually found a cotton pledget with water was actually a little better than for decontaminating implant surface than an erbium laser. But he also advocated use a diamond burr and shave down all the threads, right? The ones that aren't covered with bone, shave down all the threads. And then polish it up, and then put a bone graft on, put a membrane on, suture it over. Hey, we're done, we treated our peri-implantitis. I went to another lecture by another doctor who said he doesn't believe in shaving down the threads, and he believes that the erbium is better than anything else to decontaminate an implant surface. So a lot of the treatments that you see, that you read about, depend on who you believe or who you know. There's no set protocol out right now that says, do this, you'll get this result, and that's it. 80% of the patients and 50% of the implants at some point will develop perimucositis. 28 to 56% of the patients and 12 to 40% of implants will develop periimplantitis. That's a lot. That's a significant number. 400,000 cases, this is from 2008. In the US, 400,000 cases of periimplantitis, but there's no one else, it's funny, you'll say, how many of you see periimplantitis? And people will raise their hand. I go, how many are yours? And very few people raise their hand. So I'm just wondering who that one doctor is who has these 400,000 cases of periimplantitis. Because no one ever has failures and no one ever has periimplantitis. It's amazing. Sweden, 40% plus of implants. 1 million dental implants are removed worldwide annually. If they lasted forever, I don't think we'd have as many implant companies around. But we do, because nothing lasts forever. Just to go over quickly, I know you all know this. Periimplantitis is basically like periodontitis. It's inflammatory disease present with clinically progressive crestal bone loss after the adaptive phase, whereas peri-implant mucositis is more like gingivitis, where you don't see the progressive crestal bone loss, but you do see the inflammation, and it's reversible. I like this one. Recent scientific studies show implant failures increase the risk of heart disease among patients. Dentists, sorry. Right? You see those, you go, oh my God, what am I going to do? If you look at all the treatment options, there's no clear choice, and a lot of treatments have high failure rates. And that's the problem. There's no set protocol. No one has come up with a protocol for it. So what are we going to do for our patients? We have to find something at least to get them over the hump of getting rid of the bacteria, getting rid of the infection, stabilizing it. So again, just go through this part quickly, is factors affecting periimplantitis progression. You have your gram-negative pathogens, that's your periodontal pathogens. There's biofilm, biofilm's a big one. Then you have your iatrogenic factors, the retained cement. I call that cementitis, the inflammation caused by cement that's underneath there. In my practice, I've seen more of my referring dentists starting to do more screw-retained restorations now, right? I remember when implants were coming up, everything was screw-retained. Then it went to cementable, and now we're going back to screw-retained more because we don't want to have, if you're going to have periimplantitis, let's eliminate one of the major factors, which is the excess cement. Restorations, over-contouring, insufficient contouring, improper seating, iatrogenic factors, and other predisposing factors. So again, all the things that really affect the periodontia also affect implants. And so there is a relationship between the two. So now that I've used all of these things, I'm not endorsing anything. I just need to pull some pictures off the web to show different things. So when you're treating periimplantitis, you have a lot of decisions to make. You decide, am I going to use cow bone? Am I going to use, am I going to use horse bone? There's Equimatrix. There's a bunch of them. Am I going to use like a xenograft? Am I going to use a biomimetic? Am I going to use grandma? Dead people powder, bone. People have to work with me here. I can't do this alone. Okay. Are you going to use a BMP? Are you going to use a resorbable membrane versus a non-resorbable membrane? Or what I call the kitchen sink approach is just throw everything in there and hope something sticks. But again, if you add everything in there, how much is going to cost you and how much is going to cost the patient? There's a cost involved. And the patient goes, well, it's going to cost me $3,000, $4,000 to fix a 3 millimeters of bone around a $4,000 implant. I don't know if that's good for me, doc. Why can't I just cut away the tissue and I'll worry about it later? Or take the implant out and start again. Sometimes that's not available. Or you can use titanium granules. How would you decontaminate this implant? Some doctors say if you can't decontaminate the implant, you've got to take the implant out. Depends on who you talk to. Who do you believe? Who are your mentors? What do your mentors say? But one thing I want you to think of, what is the ultimate goal or the end point that we are treating peri-implantitis, or even periodontitis for that matter. What is the goal? Is the goal to grow bone back and have bone all the way to the top of the crest again, or is it to get the inflammation down and have a healthy, stable tissue attachment or tissue around the implant, and to stop the bone loss? My feeling is, I want to get that inflammation down. If I get bone growth, that's fantastic. If I have a stable, healthy tissue that's tight around the implant, and I don't get any bone growth and the pocket's gone down, I'm fine with that also. We got to get rid of the itis. You got to get rid of the inflammation. That to me is the goal when we're treating peri-implantitis or periodontitis, for that matter. So, you know, you got prevention, you know, hygiene every 3 months. Everyone thinks, oh, it's not real teeth, I don't have to bring the patient back. No, these patients have to be categorized as severe perio. You've got to get them in every 3 months for maintenance, take films, etc. Because this can happen. This is not one of my cases, but this is when I pulled up the web again. But you can see that's a failure, obviously. I mean, nothing, you know, it's just probably a whole bunch of things. So patients that have a history of perio, get the perio under control first. Talk about this. So we have to find a way to treat it. So I showed you the LAPIP protocol on how to treat periodontitis. And we've talked about that a lot of the pathogens that are associated with periodontitis are also associated with peri-implantitis. So if we can treat periodontitis, why can't we treat peri-implantitis in the same way? So there's the LAPIP procedure for laser-assisted peri-implantitis procedure. And basically it's the same thing that we do with the LAPIP protocol. We use the laser to remove diseased epithelium. We're not using the laser, this is interesting. One, we're not laying a big flap open like you would have to do with an erbium. Okay, we're still doing it in this type of procedure, where we, just like the LAPIP protocol. We're removing diseased epithelium from around the implant, but we're not using the laser directly on the implant surface because you don't need to. You're going to get scatter of the photons inside the tissue, reflecting off the bone, etc., and that's going to break up, that's going to decontaminate the implant surface without directly touching it. Then we use our piezo scaler to kind of flush things off. That also gives us the sonication effect to break up the biofilm on the implant surface. So we're using it to decontaminate, to clean out the surface, kind of flush things off, remove any cement around near the implant above the interface. Then we use the laser again to develop our fibrin clot. And then we adjust the occlusion, just like you would do for any case. So here are my cases now again. So here's one initial presentation. Lady came in, doesn't believe that these are not natural teeth, so I don't have to brush them. Well, now she's got inflammation all around the implant. Well, that's a problem. So we went ahead and treated her. You can see this is at least a 9-10 millimeter, this is about a 9 millimeter pocket. You can see the separation and everything else. If you try to flap this open, it's going to bleed everywhere, and it's going to be a mess. So let's get the inflammation down first and see where we are. So we went ahead and treated her with the LAPIP protocol. Here's the blood clot around there, and everyone goes, oh my God, you touched the implant. Who cares? Why are we all concerned about touching the implant? I mean, I touched the abutment there with my piezo. Oh my God, I scratched it. Oh my God, I touched the implant with my piezo. Who cares? I just went to a lecture where the guy says take a diamond burr and shave off all the threads. And we're worried about, oh my God, the laser touched the implant. Oh, my head's going to explode. That implant surface is already gone. It's already been contaminated. All I can do is make it healthier. So there you go. So that's what it looked like. 3 weeks later, she still hasn't figured out she has a brush, but look, we got natural resolution of the inflammation to come down. I didn't cut away anything, that's just the body resolving the inflammation, and that's what we have. She has to still brush. Now she's starting to brush. Here's 5 weeks post the LAPIP protocol. That looks pretty healthy. That looks nice. 3 months, looking good. 11 months, looking good. I got her, she got some religion finally. But what was interesting was I took an x-ray about a year later, and look, what I didn't expect was I had 7 threads showing on the distal, on the mesial end of the implant, and now I got 3 threads of bone to come up. Without doing anything other than getting rid of the bacteria, giving the body a chance to heal itself. I'm not trying to sound holistic, it just does what it does. Get rid of the infection, the body heals itself, just like an endo lesion. Get rid of the infection, clean it up, seal it, That apical ray, periapical radiolucency grows bone again and grows a PDL again. So look, so that's that. Here's a female in her 30s, had a median implant placed 4 to 5 years ago. She had suppuration and palpation, deep pockets, you can see the suppuration there. She went to one periodontist, he said, well, flap it open, clean it, put a bone graft, membrane, etc. She saw me, I said, got this procedure, we gotta use a laser, and we'll see what happens. Went ahead and treated her. This is what she looked like before. You can see the depth. Look, we're hubbing it on that mesial, on the mesial palatal. That's over 12 millimeters deep. That's pretty bad. Here's the bone loss around the implant on the PA. Here it is 7 months later. There's bone growth there. Things are filling in. Now it looks nice. But look at the tissue. Look how that tissue is healthy, it's pink, it's firm, it's not going to bleed anymore. And that's what we're looking for. That's what I want to see around an implant. 14 months later, the bone is still there. Tissue still looks beautiful. And she's not doing anything different than, just regular brushing, flossing, etc. And 17 months later, that bone's still there. This is a long-term solution, not a short-term fix. That's important to realize. What about this tooth here? How are you going to treat the anteriors? If you read the literature or you go to lectures on periimplantitis, a lot of them show posterior teeth, posterior implants. And they do all the surgery and everything else. What they don't show are the anteriors. What do posterior implants have? What do anterior implants have that posterior implants don't? What's the one thing? Aesthetics. If you start flapping things open in an anterior case and degranulating and everything else, things start collapsing. And a person with a high smile line, this could be a problem, a major problem. What do? Well, we'll take the implant out and start again. So here's a case. The young man came in, he's in his 30s, saw me. He was going to go see another periodontist, he was going to flap it open, do an exploratory. I didn't want to have exploratory surgery done on me on this one. So we went ahead and we treated him with the LAPIP protocol. Here's why he did surgery. We had a lot of inflammation, nodular pockets, etc. Here's the cause. This is the initial cause of what happened, is that he had the cementitis that I talked about. He had a cementoma, if you want to call it. But that opened the tissue up and allowed the bacteria to get in. So we ended up cleaning off the excess cement. Here's what it looked like 4 weeks later. Now, a lot of everyone's going to say, well, look at his papilla. He lost his papilla. Give things a chance, okay? Give gums a chance. Here it is 9 months later. The pill's coming back, no inflammation around the implant, and look how nice we maintain the aesthetics. 2 years later, that looks pretty good. No one would assume that he had periimplantitis or an infection around that implant. But here's the comparison between the two times, 2 years apart. Did I get the bone to come all the way back? No. Would you consider that case a success though? How many would say that's a failure? That's a successful case. I don't need the bone to come back 100%. I just need to have healthy tissue around that implant. And that's going to maintain things. There's another anterior case. This was treated the same day it was found by the hygienist. The hygienist saw the patient, saw that there was pus coming out of number 9, and said, Dr. Honigman, come over. I said, yeah, you have an infection, let's get this treated right away. I didn't have to make sure that I had bone graft material or the correct membranes or bring the patient back for full mouth scaling and root planing a month before I was going to treat them, or that I had my biomimetics. I didn't have to make sure anything's right. I just needed to have my laser there and my piezo, and that's all I needed. We treated her that day, about 45, it took me probably about 45 minutes, but I take pictures, so that's why it took me a little longer than normal. You can see here's the 9mm pocket that we have on the distal of number 9. This is what she looked like a month later. We lost a little bit of tissue around the top of the number 8. But number 9, you can see the resolution, how it's shrunk back in a month. 5.5 months later, it's looking about the same. She's happy with the aesthetics. She doesn't have a huge smile line, but it still looks very nice. But look at the pocket that was a 9 before that was major bleeding. It's now a 3, and I'm pushing hard on that. Almost a little over 2 years later, She needs to work on her hygiene. I'd like that tissue to come down a bit more, but it still looks good. She's happy. But more importantly, look at the bone loss. How would you treat that with a flap? Without totally ruining the aesthetics. Here it is 5.5 months later. The bone filled in. And 17 months later, that bone is still there. And 26, this is just recently actually, 26 months later, that bone's still there. It's staying there. It's the person's own bone. This is not exogenous bone I'm putting in, waiting for it to turn over. Another case, you can see the infection around the implant, around the crown. Here it is, I think this is about a little less than a year, but you can see, oh, he lost some aesthetics. Well, there's no aesthetics really on the posterior, but when you see why, it's because the doctor left, the lab put an overhang on there. So now at least, he can maintain that. But look at the bone loss. There, 7.5 months later, 10 months later, 16 months later, that bone is still there. One treatment, less than an hour, I'm done. This is a case, everyone talks about, well, what about failures? Where's your failures? Well, I don't know if this is a failure, but I can retrieve. This is a case that's kind of interesting. Here's a case we did. The patient had a loose abutment. We saw there was bone loss around the implant. We decided to treat it with LAPIP. 3.5 months later, the bone loss is still there. I wasn't real happy with this. After a while, you kind of get an idea how things are supposed to heal in properly. 9 months later, we still have the pockets, we still have the bone loss, and the reason was, and this was, everything's a learning experience, is because the implant abutment, the abutment was still loose, and it was causing probably micro movement in the area. So I told the patient, look, I got to take this off. I have to bring it down to what we call the cover screw or healing abutment level, or we're going to retreat it. Now, if I had done this traditionally and I was still getting this, how much surgery is this patient going to allow me to do? But because I had done the LAPIP protocol, I still had the tissue there. I still had the original bone. I didn't lose any bone. I hadn't lost the implant, so I could retreat it. So we went ahead and retreated it. 6.5 months later, it's starting to look better. We're starting to get reossification. It looks like it's filling in more. 9.5 months later, it's looking good. And now he went ahead and actually he got it restored and everything's looking great now. But again, you can retreat it. That's the nice thing, is I'm not cutting away tissue. I'm not smoothing out threads. It's looking good. What about this case here? How many here would take that implant out? I told the guy, you're going to lose this. He went, well, my doctor sent me to you. I said, look, I'll give it a shot. Whatever. If it doesn't work, I'll apply, whatever you pay to the cost of to taking this out and grafting it, etc. So I'm not real happy with the restoration was done by his best friend in New York City. And I said, I want to tell him to find a new best friend because that's not right. I don't care what you tell him. 3 months, this is 6 months after treatment. There's 9 months after treatment. And there's a year after treatment. Did I get bone come all the way top? Never going to happen. But I got bone to fill in, I got the inflammation down, I gave the implant a second chance. And that's what we're looking for. Give patients a second chance on these implants. There's a tissue. I mean, no one does this restoration, right? And gets into the AID, right? Look at that. That's just, my theory is they put it on backwards, cemented it, and didn't realize it until afterwards. So I can't imagine a lab actually would get that. So, but look at the tissue tightness around that abutment. That's healthy, it's pink, it's beautiful. That's what we're shooting for. This is a maintainable implant. And last year I called the GP office to see how he's doing. He still has the implant. This is now, it'll be like 3 years down the road after I did the initial, the implant's still there. As opposed to just taking it out. That's, we don't have to take everything out, give it a chance. The worst case scenario is if it didn't work, it would have come out anyway. So I couldn't be further behind by trying the LAPIP protocol first and then see what happens. Just to show you it's not me, these are some cases from other doctors. This is Dr. Michael Toms in Cincinnati. He placed a median implant. It came back 2011. Well, he placed it in 2009. Came back 2011. That's what it looked like. He actually tried to take it out, but the implant was still stable. So he said, you know what, I'm going to try this protocol, the LAPIP protocol around implants, see what it turns out to be. There it is 4 months later. No bone grafting, no membranes, no nothing. Just straight, get rid of the infection. And then it was restored a few months after that. Took an implant that every one of us would have taken out in a heartbeat and saved it, because he knew he couldn't get further behind. He could only get ahead. This is one, this happens even in Canada. You can do this in Canada. And they're very polite. They don't like to, so I'm Canadian, I can say. Anyway, so the point is that, there's another case. This is a case that people would open up, put the bone graft on, maybe smooth out the threads, suture it back, but you're going to have part of your implant sticking out of there. 6 months later, you can see that bone starting to come back with one treatment. It's definitely, the radial density has increased now in that area. In Australia, they're doing this in Australia yet, but they go backwards because it's, in the equator. I gotta get some new jokes for dentists because these aren't working. So, this is Dr. Brian James. He's a friend of mine in Australia. I think he's one of the first periodontists to do this procedures. But here's one, an anterior case again. You can see the cement on the abutment. He went ahead and treated this little old lady, treated her with a LAPIP protocol. 5 months later, the bone's back pretty much to where it should have started. Back to the crest of back to the implant abutment interface. No exogenous bone, no biomimetics, no BMPs, nothing. Just did the LAPIP protocol. Dr. Larry Finkbeiner, he placed the implant. In 2010, he saw that they had an infection. Again, it's an anterior implant. How are you going to flap this without ruining the aesthetics? He went ahead and treated it. Over the course of a year, it went from that to that to that. And this is Dr. Tom McCauley from Florida. He's nice enough to send me this case. You can see the pocket depths are 15 millimeters, 13 millimeters. These are very, very deep pockets that everyone would, take the implant out, you're not going to just start again and see what happens, get a bridge on your nose. 2 years later, this is what he had, the bone came back. And you can see the pockets that were 15 millimeters are down to 3, and even the ones on the top, on the buccal, that were 15 millimeters are half. He got over a 50% reduction in pocket depth with one treatment. And he got the bone to come back around the implant. So what are the advantages of the LAPIP protocol? It's a great first-line treatment. As soon as you see the infection, you can get started on this patient right away. You don't have to wait. You don't have to scale a root plane for a month. You don't have to make sure you have $5,000 worth of biomaterials waiting to be used. It's more conservative than traditional surgery, so you have options for retreatment because you're not removing gum tissue. You're not flapping it. You're not removing granulation tissue. You're just keeping it very conservative. So you have the option. If you need to take the implant out, you can. If you want to treat it by conventional means, you can. If you want to treat it again by LAPIP, you can. Options, 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 which we're always looking for. It's less technique sensitive. You don't have to make sure the flap is beautifully coronally positioned. You have to make sure that you know how to do a split thickness flap to have a tension-free closure. You don't have, you don't have to know how to use biomimetics. You don't have to know which biomaterial I'm going to use. It's less technique sensitive. You don't have to be perfect, just have to do it right. And it can be accomplished as soon as diagnosis is made, therefore saving the patient time. And if you add in all the things that you want to do to the patient, like I said, if you add in everything you add in to do a peri-implantitis case, bone graft, membrane, biomimetic, BMP, whatever you want to add in, PRP, whatever, it adds a cost to the patient. This is probably the least expensive option to the patient, and I think it gives some of the most, what's the word I'm looking for? I'm having a little brain thing. Most consistent results I've seen. If I don't see the results that I'm looking for, I know there's something wrong, and I can go in and retreat or figure out what's wrong with the implant. So with that, I'm going to say, they say that bon temps relais. Welcome to New Orleans. Thank you very much for having me. Yes. If I have some inflammation, the question was, when do I do a second procedure? Just like that one that I showed, if I see the bone's not healing in right, or I see there's more inflammation, I may go in and just do a second procedure. I'll give it some time, 6 to 9 months, then do it. If you have any other questions particular questions after I get off the stage, I'll actually be at, I'll be on the exhibit floor Booth 1221 if you have any other questions about this. So please let me know. Thank you again. I really appreciate having a chance to talk to such an auspicious group.
Thank you, Dr. Honigman. The C verification code for the session is 332837. Our next presenter this morning is Dr. Tara Agaloo. Her presentation